So we thought in this session it would be helpful to learn from what's being done with other patient population groups and the general population, one could argue in some ways, for two reasons. One, because that field has been studying this issue for much longer in terms of effectiveness. And two, for many cancer patients, when they have been effectively treated for their cancer, they then are very relevant for what evidence we know from these other types of approaches. So the first speaker is going to be Carolyn Apovian from Boston University.
Thank you, Rachel. It's a pleasure to be here today. What I was charged to do is to review in other populations what we know, the trials looking at outcomes in overweight and obese populations for diet, exercise, behavior modification. So I'm going to do so. Fortunately, in this field, we now have up to 15-year data. So I'm going to specifically discuss the major trials, which have a large N and are long-term, and specifically discuss lifestyle, diet, and exercise. So first, diet, and this is just a summary slide of the different popular diets that have been in vogue, some of which have been studied. Very few, but we do have a category of these diets differing in macronutrient content that now have been studied. And so on the far right, you see the macronutrient content of the higher fat, higher protein, low carb diets. And the prototype, of course, is the Atkins diet, but there are many different ones, including South Beach Zone, also the Mediterranean style diet, which is higher in fat than the low-fat diets, but more unsaturated fat and healthy fats. And then all the way on the left, you have the very low fat diets, which tend to be higher in carbs, such as Ornish. And then in between, you have iterations of left and right. And I'll show you one trial that has studied in a rigorous way these macronutrient type diets. And this was published recently. So this is the trial. It was called Pounds Lost, published in 2009, Sachs and colleagues. And what these colleagues did was assign in a randomized controlled way to 811 participants, so this was a large N, out to 2 years, so long-term, various macronutrient style diets in a fairly rigorous way. It was a real-world trial in that we didn't keep humans in cages like we can do in animals. And so this is where efficacy versus effectiveness comes in, and it's a relative term. This was a very well done trial, which you can do in a real world setting. What do I mean by well done? The behavioral piece was very intense. There were 22 group visits in 6 months, and then the visits became less frequent, but they were still there. So this is considered a well-done trial. It was controlled, but in the end, patients went home, and even though there were phone calls and food logs, the reality was, and one of the critiques of this trial is that in the end, you really didn't know what diet the patient was on in the end. So having said that, this is what was shown. And so the groups were high fat versus low fat, high protein versus low protein. And so in between there, you have a panoply of different carbohydrate content And the assigned diets, there were three of them. To the right, you see the macronutrient content, and the results in terms of change in weight are seen in the bar graphs, and you can see that whether or not, so the high protein in black, low or average protein in white, fat or carbohydrate, high protein fat or high carbohydrate in black, in three categories, and you can see that no matter what macronutrient content the diet contained, the results were similar in terms of weight loss in all categories. So for participants who completed the study on the right, all participants on the left, and you can see that participants who stayed in the study out to 2 years, they lost more weight, but it didn't matter what macronutrient content they were on. And this was controlled for calories. So the calories remained the same. It was a reduced calorie diet, all of the categories, 750 calories less than estimated total caloric intake before the diets. And so the conclusion here was that reduced calorie diets result in clinically meaningful weight loss regardless of which macronutrients they emphasize. The big critique here was that if you really look at what patients ended up eating, there was a regression to the mean for macronutrient content because of the long-term nature of the trial and because it essentially was an effectiveness study. What could you do in the real world? However, this informed us about macronutrient content of the diet. Does it really tell us whether there is any advantage between these diets for weight loss? Not really, because we did not monitor patients' food intake in a controlled setting. And that's still controversial. Currently in the nutrition world, we have intense debate and controversy regarding macronutrient content. But in order to do those trials, you have to keep patients in a metabolic chamber. And when you do that, I can just summarize very briefly that what it looks like is that there may be a metabolic advantage, metabolism increasing in a low-carb diet. That's my bias, but that's still very controversial. This is an effectiveness study. This controversy goes way back since Atkins and trials done in the early 2000s. A meta-analysis was done of very good articles and concluded, and this was published in JAMA, concluded that the weight loss on a low-carb versus a low-fat diet principally associated with the decrease in caloric intake and the diet duration, not the reduction in carbohydrates. That was in 2003. And then we had another study published in 2005, another real-world study looking at the difference between 4 different diets. Atkins, very high in fat and protein. Ornish, very low in fat. And the in-between diets, the zone diet and Weight Watchers, out to 12 months, if you give patients books about these diets, which is what these researchers did, Danziger and all, and you let them go out there 12 months, real-world setting, there's no difference in the weight loss. About 25% of patients on any given diet will lose about 10% of their body weight and keep it off at the end of 1 year, 1 quarter, in a real-world setting, and that the diet type does not predict the weight loss. The adherence to the diet predicts the weight loss. Adherence, not diet, predicts success. Another meta-analysis was consistent with these findings. This was done in 48 trials, over 7,000 patients, concluding that it doesn't matter what diet your patient is on, it matters whether or not they can stay on that diet. So this informed our 2013 guidelines, which I was lucky enough to be on the panel. We were lucky enough to review thousands of studies over 5 years. Very few met our criteria, large N, long term, but we came up with these recommendations, and I'm just going to focus on number 4, which is prescribe a set number of calories per day, and number 5, there is no ideal diet. Again, these were large N trials, long-term, and that is what we concluded. Does that mean that there is absolutely no difference between low-carb versus low-fat? If you, in a very controlled setting under metabolic chamber conditions, no. This is what we gleaned from the literature. So let's move on and talk about the trials that we did include in these guidelines. So they were large N, long term. I'm going to talk about 2 more trials. So I talked about pounds lost, where we showed that the macronutrient content did not matter. That was that was 2009. 2 trials now, the diabetes prevention program in pre-diabetic patients and the look-ahead trial in diabetic patients with type 2 diabetes. Why do I single these 2 out? Long-term data and intensive behavior modification. So we talked about diet. I'm now going to talk about behavior modification in a long-term setting. Look ahead. Over 5,000 patients with type 2 diabetes, overweight, and obesity, looked at out to 8 to 10 years. The diet was a low-fat diet, as was the diabetes prevention program. So a specific diet, low-fat, low in calories. So the caloric content was 500 calories less than needs, estimated needs. At 1 year, you see that over 10%, that 37.7%, so almost 40% of participants in the intensive lifestyle intervention lost at least 10% of their body weight at 1 year. This is a tremendous success. The intensive lifestyle intervention was indeed intensive. Weekly visits for 6 months and then every other month. But out to 8 years, there were periodic visits. So this was very labor intensive. Phone calls, intensive exercise intervention, as well as diet. And out to 8 years, in the intensive lifestyle group, a full 26.9%, almost 27%, so about almost a third of the ILI group had continued to have the 10% initial weight loss. So this is a tremendous success in a real-world setting in patients with diabetes. Did comorbidities decrease as well? Lipids, glycemic control, certainly they did as well. This trial purported to look at mortality. It didn't meet that endpoint, and so the trial was stopped in 2012. However, we did glean a lot of great information from the look-ahead trial. The Diabetes Prevention Program and Diabetes Prevention Program Outcome Study, the DPP, was a 3-year trial in patients with prediabetes, and the outcome study went out now to 15 years. This was, again, a very intensive lifestyle program. The intensive lifestyle treatment group got every weekly visits, 22 group visits in 24 weeks, and then thereafter it was every other week, and then again out to 3 years it was less frequent. However, this is considered a very intensive program. There were 2 other treatment groups, a metformin group and a placebo group, and the end result was a 7% weight loss in a year and a 58% reduction in progression to type 2 diabetes as compared to metformin and placebo group. So this was a successful trial. Now, I'm showing you here the 15-year results. And even though out to 15 years, most patients in all three groups regained their weight, you still see a cumulative diabetes incidence that is 27% lower in the lifestyle group versus placebo. And Tom Wadden says it's better to have lost weight and regained than never to have lost it at all. That wasn't me. It was Tom Wadden, one of the PIs of this trial. So, and then for every 2.2 pounds of weight loss, there's a 16% reduction in the risk of developing diabetes, again, even if you regain it. So this was a tremendously successful trial. Having said that, that was a low-fat, those two trials, low-fat diet, intensive lifestyle. If you look at the smaller studies looking at high-protein diets versus a low-fat, you do see that there's a benefit of high-protein diets. You see improvements in appetite, more satiety, and at least in the short term, better weight loss, at least out to 6 months. And what kind of protein loads are you talking about? And I'm specifically talking about 1.2 to 1.6 grams of protein per kilogram of body weight per day, 25 to 30 grams of protein per meal. There's a meta-analysis out there showing that there's an increase in fullness with higher protein intake, and this was visual analog scales. So at least in the short term, you get a benefit in weight loss because of increased satiety. The critique of this is that when you look at the other studies, looking at low carb versus low fat, and you provide an intensive lifestyle, both groups do the same, even in short-term studies, because it's the intensive lifestyle that helps the low-fat group adhere to the diet. So that's the critique of just looking at high protein and low fat. Now, protein intake in older populations becomes very important, and there are studies that show that to prevent the sarcopenia and to attenuate the sarcopenia, that in an older population, whether or not they have cancer, it's very important to promote a higher protein versus a low-fat diet. What happens in older populations is you get a resistance to amino acid intake into the cells. So you have to give more protein. There's a resistance to anabolism with oral amino acid intake. Sources of high-quality protein. So we're talking about high-quality protein in animal and fish sources, and then we also have many studies that show the benefit of nutritional supplementation in the form of meal replacements and liquid diets that are high in protein. So what do I mean by that? 20 to 30 grams for each liquid meal replacement, and you really need to make sure that the protein powders are high-quality protein to get this. Okay, so I've talked about diet, behavior modification in adult populations. I was asked to really briefly talk about pediatrics, and as prior speaker indicated, we really need to talk about preventive treatment here. But at least we now have stages. We have an algorithm recommendation from the American Academy of Pediatrics that talks about prevention in the ambulatory care clinic. And there are stages. So a structured weight management, again, in ambulatory clinics, a comprehensive multidisciplinary intervention for those based on BMI and comorbidities. And this would be given in a weight management clinic, including specialists, not just primary care providers, but a panoply of specialists in dietetics, mental health, and exercise physiology. Again, the behavior modification is more intense, and then a tertiary care intervention. I can tell you that on the right here, where you do have the ability to involve pharmacological and surgical options in the pediatric population. There are very few centers that offer this multidisciplinary tertiary care intervention. I can name them on maybe two hands, maybe one hand. So we're really talking about what to do in the ambulatory care clinic and maybe a weight management clinic. And again, this comes from the expert committee in pediatrics. You look at the BMI, the percentile, do a medical and behavioral risk assessment, and then target the intervention towards prevention in both BMI 85th to 94th percentile, and then in the obese population over 95th percentile, you're going right to treatment, whereas the difference here is that in the overweight, you're going to look for risk factors. So I'm not going to summarize any of the clinical trials that have been done in pediatrics, but to say that a family intervention seems to be the most successful in pediatrics, involving the entire family, as opposed to adults. Another moment on physical activity. The trials that I've mentioned, pounds lost, DPP, and look ahead, all incorporated physical activity into their intervention. And when you look carefully at physical activity, what we do know from these trials is that physical activity per se does not help, does not give you additional weight loss. So these are, this is a compilation of studies looking at weight loss and physical activity, and at least out to 6 months, you see that it doesn't matter that the type of the duration of the physical activity, frequency doesn't matter, but what does matter is in follow-up. When you're trying to keep the weight off, the more physical activity, the better for weight loss. So what we do know is that physical activity somehow makes maintenance of weight loss easier. And there are several reasons that are hypothesized. We really don't know fully why this is. Why doesn't physical activity help with weight loss when it's crucial for weight maintenance? The hypotheses are as follows, that physical activity simply balances and regulates energy balance. So if you are, when you lost your weight and you have some indiscretions with your diet, you can balance that with physical activity. The other hypothesis, which I think makes more sense on a granular level, is that exercise closes the metabolic gap that you see with reduced weight. So patients who have lost weight and kept it off, as opposed to those who are the same weight but have never lost weight, those patients with reduced weight have a lower resting metabolic rate than those who, the never obese. And it is thought that it's skeletal muscle efficiency that is the issue, in that those who have reduced weight have an increase in skeletal muscle efficiency, i.e. they have to work harder during exercise to get the same metabolic benefit. So that might be the reason why exercise is so important for the reduced obese. And the third reason why exercise may be so crucial in weight maintenance is because of the preservation of lean body mass. Because lean body mass is, has a direct correlation with resting metabolic rate. So those three reasons. The ACSM has a position statement. This is exercise and aging again. So exercise for an older population is important for preventing functional decline. And so we go from weight loss in a general adult population to the importance as you get older. And so the goals of exercise for seniors are not just weight maintenance, weight loss and weight maintenance, but to preserve that lean body mass from sarcopenia. And we know that as BMI increases, as you get older, physical performance test scores drop because of the sarcopenia. So as we get older, it's not just about aerobic activity, but progressive resistance training to combat the sarcopenia. And this is a bar graph showing that what aging does in terms of muscle strength loss and muscle area in black, 15% decrease in strength and muscle mass, you can regain almost all of that in a resistance training program out to 12 weeks. That's why it's so important. Okay, so let's go back to look ahead and DPP. What have we learned from these trials? This is information from the look ahead trial that went out to 4 years. Initial weight loss predicts ultimate success in that in those patients who got the intensive lifestyle intervention ILI, who were able to lose at least 10% at year 1, and there were 887 of those out of 5,000, so a good percentage were able to lose at least 10%. If you looked out to 4 years, 70% of those kept at least 5% of their weight off. If you look at a middle range of participants who lost between 5% and 10% at year 1, 40% of those individuals had lost greater than 5% at 4 years. And those participants who lost less than 5% at year 1, there was 729 of those. Only 22% kept that weight off at year 4. So the lesson learned here is that the initial weight loss predicts ultimate success. And if you combine that with adherence, what we've learned about adherence, the patient tells you how well they're going to do at year 1, and if they're not doing well on a particular diet or exercise program, change the program. If they are doing well, they're going to continue to do well. A little bit more about exercise. It's a very old study done at BU in 1989, looking at 2 different diets with or without exercise. So the 2 different diets, in blue, a balanced calorie deficit diet, a low-fat diet. The red, the protein-sparing modified fast, which is a very, very high protein diet. Those 2 groups, no difference in weight loss. And then at the end of 12 months, when the intervention is over, patients regain weight. This has been shown over and over again. If you don't provide a behavioral program beyond the intervention, patients regain weight. You even see it with Look Ahead and DPP. The lower line shows balanced calorie, a low-fat diet with exercise, and the difference here is they lose weight, just like the other 2 arms. However, with the exercise, they keep a good percentage of that weight off. And this slide has been used so many times from this study, even though it was published in 1989, because it shows the power of exercise for weight maintenance. And then this is not a study, this is the National Weight Control Registry, but this registry has really informed the public and providers what it takes to lose weight and keep it off. And this registry has now accumulated 10-year data. It has 10,000 registrants maintaining at least 50 pounds for at least 5 years. We now have 10-year data in almost 3,000 patients. And we know what they do based on questionnaire and phone calls, what they do to keep the weight off. And what they do is they eat a low-calorie diet which is low in fat, 27% fat. Again, this is just a low-fat diet, 27% fat, about 1,800 calories a day. They do perform at least 2,700 calories per week of exercise. They self-monitor by weighing themselves many daily, almost 40%, at least 20% weekly. Other self-monitoring activities, they've reduced their TV watching. In terms of structure around diet, they limit diet variety, and most eat breakfast. This provides structure. They only eat fast food once a week, and they eat less, they consume less sugar-sweetened beverages. They eat more artificially sweetened beverages, drink them. They're vigilant. They always know what they're eating. They always have in the back of their mind their caloric intake. They weigh themselves, and they do exercise. And on top of that, those who fall off the wagon, so to speak, if they decrease their exercise by about 500 calories per week, they regain weight up to 9 kilograms. If the exercise is maintained, they regain only 4.5%. This is out to 10 years. So we know that this works, and we know that the opposite doesn't work, that if the structure decreases, exercise decreases, they stop weighing themselves, they start to regain weight. This is the most helpful data that we have out to 10 years, even though it's not a randomized control trial. Long-term treatment with regular support can be effective. I've shown you 3 studies that show that even though the lifestyle intervention, the behavior is reduced at the end of the studies, that ongoing support is very important. So lessons learned. Number 1, about diet. Adherence, not the diet, predicts weight loss success. It's the calories, not the macronutrients, that determine weight loss. In a real-world setting, there's no ideal diet. You prescribe a set number of calories. And small weight losses, we really didn't talk about this, but all of these trials have shown that it's a 5 to 10% weight loss that most patients can achieve with an intensive lifestyle program out to a year, and they do reduce comorbidities with that kind of weight loss. High-protein diets, still very controversial, provide greater satiety. We need more in-depth studies looking at the exact mechanism for high-protein diets. Exercise is very important. The next speaker will talk about that. And I leave you with the key components. I'm not going to go over them, but the frequency, dietary prescription, physical activity, and behavior for the 3 main studies I've talked about today. Thank you.
Thank you very much.